Yeah, again, thanks very much for asking me to talk. The people that know me actually will say that this is my favorite diagnosis on echo. So it's actually quite a nice thing for me to talk about. So I'll take you through this condition, which I'd like to say that it's completely invisible unless you echo. You don't know that you have it unless you get a set of conditions, physiological conditions that would induce it in most patients. As I'll hopefully kind of get you to realize, without echo, it is basically undiagnosable. And you know, really, this is what echo is all about in critical care, is in a timely fashion, spotting something that you cannot spot with clinical examination or suspicion alone. So it's a great topic to be teaching about. So I apologize, there has to be a bit of physics to it, and then we'll talk about how it applies to the heart. We'll talk a bit about left ventricular outflow tract obstruction, and I apologize in advance for my diagrams that look like a 5-year-old has drawn it, but hopefully they illustrate the points. We'll go through the FUSIC HD data set, look at a couple of examples, and try and integrate it into a clinical case and clinical management options. And you know, I'm very happy to be interrupted at any point if anything is not clear, but maybe the best way to do it is just to put your comments in the chat and we can address them at the end unless it's something burning that needs to be addressed at that moment. So let's carry on. Again, apologies for my bad diagram, but this is the heart as I see it, and hopefully you'll recognize it as a parasternal long axis view. So, and just to be clear that this is the right ventricular outflow tract. This is the interventricular septum, left ventricle. Here we have the aortic valve, mitral valve, left atrium. So hopefully that's a very familiar kind of anatomical diagram for you all who've done FUSIC heart. I'm going to introduce you a new structure that's not really discussed in FUSIC heart at all, but you know, in my opinion, probably should be. So it's this structure here, the left ventricular outflow tract, and of course it's important because all of cardiac output leaves the heart via this small tube. So it's funny that we don't really give it its due. Let's talk a little bit about this tube. So this is how all of cardiac output escapes the heart, and it does through during systole. And the tube is wide enough, short enough, and the pressure gradient across it is such that flow should be laminar. So as in depicted by my arrows. And if flow is laminar, which it is during almost all circumstances, then you can easily calculate the cardiac output, as you know, with some simple maths. The nice thing about the left ventricular outflow tract is that it's roughly cylindrical, circular in cross section, and it stays roughly the same size throughout the cardiac cycle, which is helpful for calculating the stroke volume. So the radius you see there, you beg your pardon, 2 pi r is the area of that circle, times by this distance gives you the volume of this tube. And this distance we can very nicely measure with something called the stroke, with the VTI, or the velocity time integral, which is a distance that a blood cell moves through the left ventricular outflow tract during 1 beat. So this is the distance times by the area of this tube gives you the stroke volume. And this is the stroke volume times by the heart rate, you get the cardiac output. I think that's another talk, but I thought I'd quickly mention it because it has relevance here. Now, we hope blood is funny, it's a funny fluid. It sometimes acts like Newtonian fluid and sometimes doesn't. Let's just assume it is for argument's sake. Now, flow is generated by a delta P, the high pressure, in this case, generated by the left ventricle contracting, and the low pressure, in this case, aortic pressure. So once the pressure within the left ventricle exceeds that of the aortic pressure, the aortic valve opens and blood starts ejecting. Again, the tube is wide enough and the delta P is such that it results in laminar flow. This is the formula for laminar flow, and there's some things that we can't do very much about. So we just ignore them. And as a result, you can see that delta P is related to the flow and the radius. So really, really very straightforward. but it also implies that the flow is related to delta P and the radius. And we have to bear that in mind when talking about stroke volume and how it changes once, in particular, the radius is altered, because that is what we're talking about with left ventricular outflow tract obstruction. We're talking about a reduction in the radius. And you can see it's to the power 4. So any change in the radius would have a big impact on the delta P needed to maintain the flow. I hope that's pretty straightforward to see. And why is laminar flow so important? Well, because all fluids at some point will transition from a laminar flow to turbulent flow. Now there's this gray zone where there's kind of mixed flow, but there's no point in dwelling on this complexity. At some point, laminar flow will transition to turbulent flow. Of course, same situation applies. It's related to the velocity of the fluid moving through this tube. Now, the really important thing to say about turbulent flow is that the delta P required to move a volume of blood under laminar flow is much, much less than the delta P required to move the same volume of blood, which is turbulent. So that's a really important concept which has clinical consequences, which we'll discuss later. So the idea is, of course, that the heart and us want to keep all flow through the left ventricular outflow tract laminar, because the left ventricle has to generate a lot less pressure to eject a certain volume of blood than if the flow was turbulent. So this graph, I think, demonstrates this quite nicely. The green line is laminar flow. Now, if you increase the driving pressure, the delta P, you should get an increase in the flow ejected from the heart, as long as the flow stays laminar. So, and that's kind of what happens when you exercise or when you have an increased metabolic demand. The cardiac output increases to match, and it does this by generating more contraction of the left ventricle, which generates a higher delta P, and the flow rate goes up. Fantastic. The problem is when this situation then transitions into turbulent flow, you can see that the same increase in your delta P doesn't actually result in an increase in your flow. So that's a bit of a disaster. So the heart will try its best to generate higher pressure to eject more, but actually it's just resulting in more turbulence, and therefore doesn't actually result in much more ejection. So you get the consequences of actually a reduced amount of ejection, a reduced cardiac output, but the left ventricle is generating very, very high pressures, which backtrack into the left atrium, back along the circulation with predictable consequences. So turbulent flow, bottom line, bit of a disaster. And just to recap what we said, this is the left ventricular outflow tract. We wanted the flow to be laminar. It's generated by delta P, and the high pressure is generated by the left ventricle, low pressure is generated by the aorta. It's all to do with the radius and the delta P. So let's take an example where this radius, for whatever reason, has been decreased. I've drawn a kind of weird pink thing, which is meant to approximate what left ventricular hypertrophy might look like in the septal area. So this is quite a common finding actually in elderly people with hypertension. They get this kind of septal hypertrophy, which results in a sigmoid-shaped left ventricular outflow tract. So it not only causes narrowing, but causes a kind of curvy path, again, which can induce turbulence. Our left ventricular outflow tract cylinder here is obviously much narrower, but day to day, patient won't have a clue. They come for an outpatient echo, there's absolutely no signs of left ventricular outflow tract at all, obstruction at all. It's only when physiological stuff happens or ITU happens or anesthesia happens that we start to induce left ventricular outflow tract obstruction in vulnerable people, which we'll talk about. So, risk factors. Well, we have the physiological related, and let's talk about those because these are all things that we manipulate on a day-to-day basis for all of our patients. So we need to understand the consequences of what we're doing to people, and in particular, how certain people can react very badly to what we do. So reduced left ventricular end diastolic diameter, i.e. low preload. So low preload is a function of many different conditions. I'm not going to go into them all, but that is one of the cornerstones of our management in ITU is to restore preload. Low SVR state, i.e. some sepsis or inflammatory state, and a hypovolemic state are really common findings in intensive care. And of course, those two things, most patients will respond to those situations by increasing cardiac output to try and fill up this low afterload hypovolemic circulation. But it does that by increasing heart rate and increasing contractility. So that could be a problem under certain circumstances, which we'll talk about. And you can obviously induce the hyperdynamic state with uncontrolled inotropy. There's also certain conditions which, if you take out the apex of the heart for whatever reason, the base becomes hyperdynamic and tries to maintain overall ejection by shifting the bit of the heart that actually works. The two very common examples are an anterior MI, which takes out the LAD, so the apex doesn't work, but the base is maintained as long as it's not too proximal, and of course a stress cardiomyopathy. So both these things take out the apex, the heart tries to compensate, and the base becomes hyperdynamic. And we'll talk about that particular situation in a moment. Let's look at people with anatomical problems. And of course, people with anatomical problems are going to suffer physiologically related left ventricular outflow tract obstruction much earlier than people without anatomical problems. So these people are already predisposed to developing complications related to these set of physiological conditions much earlier. And of course, the classic ones are thick walls, small cavity, in particular the sigmoid septum that you see classically in elderly hypertensive ladies, HOCM, and cor pulmonale. And that's quite an interesting one to stick there, but I'll explain why that's there shortly. So that's if the left ventricular cavity is small. And the other thing is, if the mitral valve is diseased, it can actually push its way into the left ventricular outflow tract obstruction. And the most common things you really see are degeneration of mitral valve or after mitral valve surgery. So let's talk about functional obstruction. Now, these patients live their lives day to day with absolutely no problems. They have their outpatient echo and it is reported as basically normal, or, you know, a little bit of hypertensive cardiomyopathy or whatever. So everyone's very reassured. But when they get septic, or they get hypovolemic, or you accidentally think they're having anaphylaxis and stab them in the leg with adrenaline, you are then creating a certain set of circumstances which can be the perfect storm for these patients. So again, let's recap that. You have a low preload on the background of a small empty cavity. Tachycardia or tachyarrhythmia, remember, that reduces left ventricular filling. So it has the same effect as having a low preload. So a empty heart, a fast heart, a heart that's beating hard, it's hyperdynamic, in combination with a patient with a low afterload, for whatever reason. And this can result in a perfect storm to get this bit of heart to move closer to this bit of heart, narrowing this left ventricular outflow tract and causing a transition from laminar flow to turbulent flow. And as soon as that transition starts happening, not only do you have the physical obstruction of having a small, narrowed left ventricular outflow tract, you now have turbulent flow, which we already said doesn't actually result in much ejection, just results in turbulence. So big problems. And trust me, you can actually induce this in any person, even healthy hearts, if you try hard enough. And actually, they did this study, which is, I definitely wouldn't want to be randomized to the I want to induce left ventricular outflow tract obstruction when critically ill group. But here in the 90s, they've done it. Giving enough dobutamine actually can induce left ventricular outflow tract obstruction in normal hearts in 20% of cases. So this thing can be done. So let's talk about physical obstructions. This is another example of a bulky septum here. And here is a, I don't know, thick mitral valve. And both these things can move into the left ventricular outflow tract and cause a narrowing of ejection. So if you have anatomy-related predisposition, very few patients know they have left ventricular outflow tract obstruction at rest. And these patients tend to get referred to cardiac surgical centers and tend to get their septums shaved or their mitral valves replaced. So if it's spotted as an outpatient, it tends to be dealt with pretty rapidly. These patients as I said, they don't normally have any signs or symptoms or even echo findings at rest. But these are the ones that will develop left ventricular outflow obstruction much earlier in a disease process than normal hearts, or you can accidentally induce it with inotropy or other measures we do in intensive care. The other good one, which not many people think about, is what happens when you have a big right ventricle. So as your right ventricle dilates up, remember the heart sits in a sac. It's called the pericardium, and this pericardium is inflexible. So there's only so much space for both ventricles within this sac. So they're like a marriage. And as one gets big and annoying, the other one gets squished. So if the right ventricle dilates up, it actually squishes the left ventricle, causing all of the physiological conditions we've talked about, and actually physically shifts the septum into the left ventricular outflow tract. So it causes double problems. And such patients, as I'm sure you've come across, are smokers with some chronic cold pulmonale who develop a pneumonia. Their right ventricle dilates up a little bit more, decompensates very readily. Suddenly they're on CPAP or NIV, or you've intubated them, and now they're in a shock state. And if you echo them, you might find exactly this physiological state of the right ventricle dilating up really easily because it's prone, it's got a tendency to do so with a little bit of intrathoracic pressure application. And your shock state isn't in fact sepsis or whatever other thing you put on the death certificate. It's actually a physical obstruction. That, if you spot, you can actually try and treat. So I want to make the differential in your minds between left ventricular outflow tract obstruction and SAM. And SAM is not your mate. Sam is the organizer, of course, of this lecture series. So he is your mate. But SAM in this case is actually systolic anterior motion of the mitral valve. Now, people think you can only have left ventricular outflow tract obstruction if you have SAM, or left ventricular outflow tract obstruction causes SAM in all cases. So people look for SAM when they're looking for left ventricular outflow tract obstruction, but they can occur together, or they can occur, a left ventricular tract obstruction can occur by itself. So let's look at this. This is a patient with a bulky septum. This is the route of ejection for any blood. And what happens is the speed of this blood, because it's already narrowed and going fast, drags in the mitral valve. It can either drag in just the anterior mitral valve, pulling apart the mitral valve itself. And obviously this is during systole when the mitral valve should be closed. And this results in MR, posteriorly directed, like seen here. Or it can drag the closed mitral valve, both leaflets, into the jet stream and cause further obstruction. So it is true that patients with left ventricular outflow tract obstruction and SAM tend to have a more narrowed left ventricular outflow tract, and they tend to be more shocked. But you can have left ventricular outflow tract obstruction without SAM. But it can cause SAM, and SAM can cause left ventricular outflow tract obstruction. You can have MR, or you can have no MR. So I hope that's clear that it's a feature of it, but not, if it's not there, it doesn't mean it's not there. Now, I apologize for showing you a TOE, because I appreciate this is a Futic HD lecture, and you're probably not used to looking at TOEs, but it's such a beautiful example that I couldn't help myself. And if I take a second just to show you the anatomy, you'll find it useful. So up here, this is the left atrium. This is the anterior mitral valve leaflet. This bit's the left ventricle. This bit's the left ventricular outflow tract, and this is the aortic valve. So bear in mind that the blood comes from here into here and out this way. And with that in mind, watch this video. Amazing, right? Well, so the answer to that statement is actually it's not amazing, because this is really, really hard to see. Like what you're looking at, who knows? Like, you know, it's a fast hypodynamic heart, you know, who cares? So the thing about left ventricular outflow tract obstruction, which is so exciting, is that if you don't actually look for it and keep it in your mind as a thing, you're going to miss it. So you've got to keep it there in your head and actively look for it. And how do you actively look for it? You have to go slow. So let's look at frames. This is, of course, diastole. So the mitral valve is open. Now, you would say, oh, you know, this anterior leaflet of the mitral valve is completely obstructing the left ventricular outflow tract. But the left ventricular outflow tract in this part of the cardiac cycle is not being used. There is no flow out of the heart. So all flow is from the left atrium into the left ventricle during diastole. All looks great. Thank you very much. Okay, well, so the left ventricle is starting to contract. So the mitral valve is now closing, and you're seeing the start of isovolumetric contraction. So both the mitral valve and the aortic valve are shut, and pressure is now building up in the left ventricle, ready to overcome the pressure in the aorta, ready to force open the aortic valve. Everything still looks good. Okay, fantastic. This is looking great. Mitral valve is closed, aortic valve is open, a beautiful left ventricular outflow tract. Lovely, like fantastic, happy, delighted. Oh, well, this is interesting. So you can see now that the folded left mitral valve, the anterior and posterior leaflets, instead of like it sitting in the cavity nicely, it seems to have been pulled into the left ventricular outflow tract. In fact, it's almost obstructed half of the whole diameter of the left ventricular outflow tract. But no biggie, it still seems closed, and the aortic valve is still open. So if the aortic valve is open, it means there must be blood flowing out of the heart. So maybe it's not that bad. Oh, well, that's actually not great, because that mitral valve seems to be now obstructing 2/3 of the left ventricular outflow tract. So here, this is the posterior leaflet, this is the anterior leaflet. Blood is now only able to eject out of the heart, this very, very small narrow opening here. Now the aortic valve, you can see, it started to almost stutter a bit. And if you were to play the video back really slowly, you could see aortic valve fluttering. And I really wish I had a more exciting surname, because I call it the Aron sign, the fluttering aortic valve, because you can diagnose impending arrest from left ventricular outflow tract obstruction based on the fluttering aortic valve. Now, of course, the aortic valve shouldn't flutter. It should go. If it's fluttering, i.e. it's trying to close during the middle of ejection, during the middle of systole, it implies that flow is slowing down or even stopping. So if it's doing this, like that, then at some point during mid-systole, there is either flow reduction or flow cessation. So the aortic pressure is suddenly overcoming left ventricular outflow tract pressure, and the aortic valve is starting to close. That's bonkers during mid-systole. So that's a full interruption of cardiac output during systole, which is a pre-terminal event. So if you spot the aortic valve fluttering during mid-systole, I'll take that very seriously. Okay, this is very exciting now. So the anterior mitral valve leaflet seems to have completely occluded the left ventricular outflow tract. The aortic valve is still fluttering. But here now, importantly, you can see that this valve's now been ripped open. So if there was color applied here, you'd see mitral regurgitation directed in this direction posteriorly, because it's TOE, it's the wrong way around. So here you can see now it's near the end of systole, which is probably premature because the left ventricular outflow tract is completely blocked by the mitral valve. So the aortic valve is closing, the mitral valve is still open, and the aortic valve is now closed fully. And this is now the end of systole, and diastole is about to start. Mitral valve will open shortly. The systole has terminated early because the left ventricular outflow tract has been obstructed. So you wouldn't see any of that. If you think back to the video, which was going fast, you didn't pick apart any of those things. So you have to keep in your head, you have to get a good picture of your left ventricular outflow tract, get a few cardiac cycles, and importantly, get a respiratory cycle. That's really exciting why that is. But I'll just make my first point. Get a few cycles, freeze it, scroll back and forth slowly. Look at the ECG, look where you are in the cardiac cycle. Is the aortic valve fluttering? Is the mitral valve being dragged into the left ventricular outflow tract? Is the left ventricular tract narrowing in the middle of systole? So look for it, actively look for it. The other important thing about looking over a respiratory cycle is because, of course, filling changes between inspiration and expiration, depending if you're spontaneously breathing or mechanically ventilated. The preload changes over the respiratory cycle. So if a patient is really on the edge, at the time when the preload is low, you might see obstruction, complete obstruction. the time in the respiratory cycle when the preload is higher, you might see partial obstruction. Again, if you see complete obstruction in a certain part of the respiratory cycle, that is a disaster. That is a pre-terminal event. You've got to do something about it. Otherwise, you'll be doing CPR. And, it's just, no one looks good doing CPR. Doesn't matter how well-fitting your scrubs are. So let's talk a little bit about what happens if you block your left ventricular outflow tract obstruction. Of course, there's little or no ejection. So your skin looks like this. And if your skin looks like this, the rest of your organs look like this. So your brain, your kidneys, your gut, I don't know, whatever other organs you hold near and dear to yourself, all look mottled. So that's bad. The left ventricle, though, is working overtime. It's trying to desperately squeeze harder to overcome this obstruction and squeeze more blood out. But the very nature of it squeezing harder means it's actually causing more obstruction in some perverse kind of twist. But the point is that this high pressure then backs up to the left atrium. The pressure then causes pulmonary congestion and, of course, pulmonary edema. And actually, that can increase your RV afterload and cause RV failure. So not only do you have a low cardiac output state, you also have high left atrial pressures and pulmonary congestion. And I don't know if this syndrome sounds familiar, but it is actually exactly the same as cardiogenic shock. And you can read documents to your heart's content about how to diagnose cardiogenic shock. But on the whole, most people say it is a low blood pressure, pulmonary congestion, and organ hyperperfusion. So cardiogenic shock looks exactly like left ventricular outflow tract obstruction clinically. Now that's a worry. And why is that a worry? Because you think this is cardiogenic shock, you've read this document, you think, brilliant, I've recognized this is not sepsis. You can rip your could this be sepsis badge off your scrubs and you can stamp on it in protest. You think, right, I'm going to admit this person to ITU. I am going to do all the things I'm going to do, which is give them CPAP. I'm also going to be really good and I'm going to give them some inotrope, some dobutamine, 5, 10. I'm also going to give them some furosemide and dry them out because that's what I do to people in pulmonary edema. And now you understand that if it's actually left ventricular outflow tract obstruction, all those things make it worse. The dobutamine makes you more hydrodynamic, causes more obstruction, more turbulent flow. That's bad. The furosemide, perversely, venodilation, decreased preload, diuresis, even if your kidneys are still being perfused at all, hypovolemia, low preload. So all of these things are actually making your LVOT obstruction worse, not better. And of course, it's a death spiral that unless you spot its LVOT outflow tract obstruction versus typical cardiogenic shock where your left ventricle is not moving, then you're going to kill the patient. Not intentionally. I mean, whatever's cause is going on is having a role. You certainly aren't helping in the way that you would want to. I hope the clinical components are relatively clear, and I'm very conscious that it's an echo talk. So let's talk a bit about how you diagnose it on echo. To me, 2D is the most important thing. And the key step from Fusic heart scanning to Fusic HD and thinking about left ventricular outflow tract obstruction isn't fancy measurements of color or any of the other knobs on your machine that you can't wait to like twiddle and twist. Actually, it is just taking a loop, pausing it, looking at it slowly over the cardiac and respiratory cycle that we talked about, and actually looking for anything that's narrowing that left ventricular outflow tract. That is the key thing. So on 2D scanning, you can spot all the risk factors we've talked about. And I get really excited when I see a heart that has the potential for developing left ventricular outflow tract obstruction, because it is really key information about what I can and cannot do safely in that patient in now and in the future. So a small cavity, thick walls, the sigmoid septum, a classic stress cardiomyopathy type picture, or a large anterior MI, or patients with large right ventricles are all, for me, big risk factors in developing physiologically induced left ventricular outflow tract obstruction. If the patient has physiology that results in a hyperdynamic tachycardic state, even more reason to worry. And then looking to see if it's there or not. Again, you can look for narrowing directly in the parasternal long axis. You can look for this fluttering of the aortic valve or closing early of the aortic valve in various views, the parasternal long axis, the apical 5 chamber, the apical 3 chamber. And if you really want to save some images for a future talk of your own, then you're going to find SAM, and you can find that in various views: parasternal long, the apical 4 chamber, apical 2 chamber, 3 chambers, and subcostal. So, and you can look for SAM without the need for color. So here's a good example. Here is obviously the 5 chamber. You can just see the aortic valve here. And actually this is the mitral valve, which is calcified. But here the patient has a small cavity, thick walls, septal bulge going on here. So all the risk factors we've talked about. The heart rate's not fast in this case, but actually you can see this here, this folded mitral valve has been dragged into the middle of the left ventricular outflow tract during the middle of systole. This is the QRS complex, just after the QRS complex. Here it is zoomed in. So you've made a diagnosis of SAM and left ventricular outflow tract obstruction without any other fancy measurements. You can see it in M mode as well. So in the parasternal long axis, put your M mode cursor through the mitral valve and kind of watch it move towards the septum. Clearly, it should move towards the septum during diastole, but it shouldn't move towards the septum during systole, as it is in this case. So you get this M pattern, and you can see it's coming pretty close to the septal wall during systole, resulting in complete obstruction. I know you guys are itching to use color, so here's some color. Whack it on, and the first thing you see is turbulent flow. So, you know, turbulent flow, it's 65, 70 centimeters per second flow. So really, you shouldn't be getting flow faster than that through the left ventricular outflow tract during HAL. That shouldn't happen. So, yeah, you get this turbulent flow, and it doesn't happen at the aortic valve level because that would be indicative of aortic stenosis. It happens before the obstruction, which is here, before the left ventricular outflow tract. So you see this turbulent flow pattern here, and in this case, of course, you also see MR, which occurs, sorry to state the obvious, during systole, and causes this kind of pattern of turbulent flow in the left ventricular outflow tract and turbulent flow from the mitral regurgitation. And you can see that various views, parasternal long axis and the apical 5 being the best. So, and if you do see MR, it's posteriorly directed and often very severe because the mitral valve has been ripped open. Spectral Doppler, again, in the apical 5 or apical 3 chamber views. The first thing to say is that you'd see very high velocity blood because that's a prerequisite for developing turbulent flow. So velocities above 1.5 meters per second with a normal looking aortic valve that's opening should raise suspicion of on obstruction. It could be left ventricular outflow tract, it could be intracavity, but either way, it's the kind of pathology that you should take very seriously because to generate very high velocities requires very high pressure. So something's working very hard when it shouldn't, and it's often very easy to treat. You get this distinctive pattern, which I want to show you here. I think I've got some, just to remind you, this is what the normal pattern looks like before we move on. So this is a waveform, a left ventricular outflow tract VTI waveform. And just to point out the key features, velocities build up very rapidly because the delta P is gentle, it's relaxed. The aortic pressure doesn't, and the aortic valve doesn't offer any resistance to flow. So the flow becomes maximal straight away within a few milliseconds. And then, because there's plenty of time during systole, the flows drop down gently. It's laminar. You can see that because this is hollow. So all the velocities that you're measuring are occurring at all the velocities are the same velocities. In turbulent flow, when all the velocities are all over the place, this waveform is filled in. So the fact that this waveform is hollow and the upstroke is very rapid and the downstroke is gentle, this implies this is a normal flow through the left ventricular outflow tract. So compare it to this situation, which is exactly the opposite. So you have a few features here. The first thing is that the isovolumetric contraction time takes a long time because you have an obstruction to overcome before the aortic valve opens. The next thing is that this waveform is slow rising. It doesn't happen quickly. It happens over time to build up the maximum velocities because there's an obstruction. And you can see that, so this gradient is much, much more shallow than this steep one here. In fact, here you can see an interruption of flow, which corresponds to the aortic valve fluttering. So at one point, there's almost complete obstruction, flow starts to drop, and the aortic valve starts to close. So the peak velocities are late in systole rather than early in systole. And then because you've taken so much time to get to peak velocity without much time left in systole, there's a rapid deceleration in the blood velocity to the end of systole. So it's a very different waveform in this situation. Now, if you're interested, I think hopefully I've shared this with Sam, this document. This is a document which talks all about these things, and you've got a free PDF on me based on it. So just again, to remind you of the consequences of this situation, the patient has a cardiogenic shock phenotype and usually has a really high lactate. And the patient may be getting worse, not better, despite starting your conventional therapy, which we talked about, inotropy and reduction in preload. The echo show signs of left ventricular outflow tract obstruction, could show signs of raised left atrial pressure, could show signs of acute cor pulmonale and venous congestion. So you can get the whole shebang. I want to just, I'm conscious that we're running out of time, show you that there's lots of different abnormal waveforms in a patient with left ventricular outflow tract obstruction, but it almost doesn't really matter. If you're looking at the waveforms, then I would suggest that you've got extra time in your hands. You can make the diagnosis with 2D and color alone. But just for your knowledge, that the LVOT obstruction waveform is late peaking, slow rising, as we've talked about, with an interruption in the middle of systole. The mid-cavity waveform, which is a surrogate of kissing papillary muscles on your Fusic heart scan, again, has a very late peaking waveform, but actually it's even sharper. So the velocities hit astronomical levels. But overall, the velocities are lower than a left ventricular outflow tract obstruction. And then the mitral regurgitation, which again, you can get confused if you're not careful about where you put your cursor, looks very different. It's pan-systolic, rounded like this, parabolic, and has very high velocities indeed. So the highest velocities of the lot. I actually cannot remember what I intended to show you there, but these are some waveforms which are typical for left ventricular outflow. Oh yes, I remember. Sorry. So if you have very high velocities and turbulent flow and the patient is shocked, you can actually try and use the pulse wave sample box to work out where in the ventricle the obstruction is. Again, I would suggest if you're doing this, you have more time on your hands than sense, but this is something that's talked about, technique. So you put your pulse wave Doppler here, and actually the velocities 1 meter per second, not that exciting. You put the velocities now in the mid cavity. Here, the velocities are getting to 2 meters per second. So that's much more impressive. And here, the left ventricular outflow tract obstruction, you're getting this typical waveform, interrupted mid-systole and slow rising, late peaking. So actually this patient has both mid cavity and left ventricular outflow tract obstruction. Again, the differential is almost academic because the treatment is the same for both. Which is, you're going to do your best to reduce the functional components and hope that you can bring the patient back from the brink. So you've got to try and reduce the patient's endogenous inotropy and tachycardia. And you do that with sedation, analgesia, and try and reduce their metabolic demand as much as possible. You try and also reduce their exogenous inotropy. So that's the stuff that you're doing to them. Remove any physical obstruction if that's possible. So if you have cor pulmonale and a big right ventricle causing obstruction, you should prone the patient or try and reduce the PEEP or introduce nitric oxide, thrombolize if it's due to a PE, or think about ECMO, because ECMO, the ECMO in particular, obviously drains the right ventricle, so reduces the compression of the left. If you have systolic anterior motion of mitral valve, then the way to do that is to try and reduce the velocities moving through the left ventricular outflow tract. So again, it's your physiological strategies that predominate: fluid and a reduction in inotropy and a reduction in tachycardia to increase the filling of that left ventricle will reduce the velocities moving through the left ventricular outflow tract and reduce the drag on the mitral valve. If there's a septal bulge that's causing obstruction, then again, you're back to your managing your physiology as much as possible. You can try and force open the left ventricular outflow tract. So you improve ventricular preload, which is give fluid, control any tachycardia or tachyarrhythmias, including shocking them if needed, and keep the left ventricular tract open. And this is actually around, bizarrely, maintaining, oh my God. Am I still online?
Yes, you are.
That's good. I'm just going to, the fuse is gone. I'm just going to switch back on 1 second. Wonderful. Well, that's not worked. Anyway, as long as I'm online, it's all good. Maintaining LV afterload, systemic vascular resistance, is really important, because remember, we talked about how a low afterload, a septic state, actually induces this further, makes the ventricle empty more, and lets the left ventricular outflow tract narrow more if predisposed to do so. So in addition to everything we've talked about, actually, if you use arterial constrictors like high-dose noradrenaline, although noradrenaline is not the right drug, as we'll talk about shortly, if you maintain afterload and prevent a reduction in your afterload, it might actually help. So why I say that not high-dose noradrenaline is not the right drug is because, of course, that noradrenaline has some intrinsic inotropic activity. So if you really are inducing left ventricular outflow tract obstruction with inotropy, you probably want to maintain your afterload with vasopressin, not noradrenaline. If you've accidentally put in a balloon pump, I would suggest taking that out as well. You can also think about bypassing the left ventricular outflow tract completely by sticking an impeller through it. But that's a difficult decision to make, because the impeller could get blocked by the very mechanisms that are causing the obstruction. So not an easy decision either. I got a quick case, and then we can talk about the other thing that Sam wanted me to talk about. A 49-year-old male had an out-of-hospital cardiac arrest with 20 minutes of CPR before he sustained ROSC. In the cath lab, he had unobstructed coronaries, so no interventions were made. He was intubated in ICU on high-dose noradrenaline, but with MAPS only in the 60s. He was core peripherally with lactate at 3, and he'd been oliguric for the last 6 hours. Just in the interest of time, hopefully you'll all see a hyperdynamic tachycardic heart. Image quality is not great, but given that this is a talk about left ventricular outflow tract obstruction, maybe you're looking for it in this view, which would be the right thing to do. So, unfortunately, this wasn't put together well, so milrinone was added because of his low cardiac output state. Now, if you see a hyperdynamic ventricle moving like that, I would suggest that milrinone is not the right treatment. But 4 hours later, which may have been predictable, and just to say, milrinone is probably the worst drug for this kind of situation, because it takes 2 or 3 hours to work, but also takes 2 or 3 hours to stop working once you push the stop button. It reduces the afterload quite a lot, and of course increases contractility. It actually causes less tachycardia, which is its only redeeming feature. So 4 hours later, he's currently on more noradrenaline. His lactate is now 9. He's completely anuric, and he's now in florid pulmonary edema. So now probably your eyes are able to adjust to the speed. It's faster, of course, but you get the point that now, because of the hyperdynamic state and the sigmoid septum, that mitral valve is now causing obstruction. Here you can see it very nicely on M mode, that double M peak that we talked about. I think you can probably see it there, the folded mitral valve being dragged into the jet stream, and it's ripping apart the mitral valve during systole and resulting in this very profound mitral regurgitation, which is coandering, hitting the back wall. You can even with the IFA see it going straight into the pulmonary veins, into the lungs, causing the pulmonary edema in itself. And if you need further evidence, there's the mitral regurgitation. And here is the turbulent flow, which is occurring at the site of this septal bulge, not at the site of the aortic valve. And here you can see the scale is set to 96 centimeters per second. So the fact that this is aliasing means that this is over 1 meter per second at the septal bulge. This is very fast indeed, very turbulent flow. These are the waveforms, which again, late peaking, slow rising, quick terminating waveform, which we talked about. So the neuroneuron stopped, fluid was given, and within 2 or 3 hours, it was down to FiO2 of 0.35. Norad was right down, and he started passing urine and warmed up very nicely. So again, a diagnosis that could only really be made on echo. Actually, the initial strategy, even with a very simple focused echo, was probably wrong in retrospect. So just to give you some cautionary notes from my bad experiences, just be cautious about VTI, LVOT VTI, when there's turbulent flow. The formula actually relies on laminar flow. So if you use the VTI to calculate cardiac output when you have turbulent flow, then your cardiac output will read erroneously high. So please don't be falsely reassured by that. Your left ventricular outflow tract obstruction can exist with a very poor left ventricular ejection fraction. If the base is the only thing moving, but still causing obstruction, actually, the patient's much more shocked because the apex can't generate any high pressure to overcome the obstruction. So your patient's often in a worse situation than if the left ventricle is actually moving properly. If you really want to make a legend for yourself in a patient with pulmonary edema, give them fluid if they have left ventricular outflow tract obstruction, because immediately their pulmonary edema will get better, and that will live on long past your rotation. And if you spot the potential for developing a patient with left ventricular outflow tract obstruction, please let someone know, because later on, when they're weaning and people are giving industrial doses of furosemide to try and get them off the ventilator for no good reason whatsoever, you might actually end up inducing left ventricular outflow tract obstruction by getting them too negative, or some other reason that might happen. So if you see all the risk factors that we've talked about, please make the point that this patient could develop it under a certain set of physiological circumstances. And those physiological circumstances should be avoided at all costs. And indeed, if the patient develops a shock state, another echo is required to make sure it's not obstruction. So my concluding statements are, it can mimic cardiogenic shock, but all the treatments that you give for cardiogenic shock make it worse. So very easy, 2 seconds, maybe 2 minutes. You can spot the potential for inducing left ventricular outflow tract obstruction. You can spot it on a 2D scan. You can diagnose it with color flow. You can quantify it with spectral Doppler, and then the consequences of left ventricular outflow tract obstruction, if required, can also be spotted with echo. So the whole point is, if you recognize it, you can treat it. If you don't recognize it, then the condition is undiagnosable. So I will stop there and